Welcome to this episode of Conceptual Anesthesia. And today we'll be talking about simple topic, but it's a slightly longish topic, pulmonary embolism. So just stay with me for around 40-45 minutes and it'll be a good class. So what is the definition of pulmonary embolus? It refers to the obstruction of pulmonary artery. So there is a obstruction of pulmonary artery or one of its branches by material. So usually it's a thrombus coming from somewhere else in the body, but it can be a part of tumor or air embolism or fat embolism after a long bone surgery. So how do you classify pulmonary embolism? So it can be classified by either the temporal pattern like acute. So in patients with acute pulmonary embolism typically develop symptoms and signs immediately after. So here the keyword is immediately after. In subacute, it is after days or weeks, and in chronic, it is after over the many years, so months to years. But usually, what we encounter in critical care is usually hemodynamic instability. So, what we used to call as a massive pulmonary embolism or a hemodynamically unstable pulmonary embolism usually happens in a high risk patient. So, this is a medical emergency. So, you have to act immediately. So, remember the patient there is hemodynamically unstable. It is also called as massive pulmonary embolism. It can be submassive or intermediate risk if it is with right ventricular strain, and low risk when there is no evidence of right ventricular strain. So in the overall, I'll describe hemodynamically unstable right now, and strain will be describing later on. So what is hemodynamically unstable? So either the systolic blood pressure is less than 90, or there is a sudden drop in blood pressure, or the blood pressure drop is so high that you require inotropes and vasopressors. And remember, it is a diagnosis of exclusion. So it should not be explained by anything else like sepsis, LV dysfunction, by MI, hypovolemia, or arrhythmia. So remember, hemodynamically unstable or a massive pulmonary embolism is a medical emergency. Now it can be caused of anatomical location also. So it can be saddle. Saddle means that we have a right and left pulmonary artery. When it is along the bifurcation, it is called a saddle pulmonary embolism. Then there is a lobar pulmonary embolism, and then there's a segmental pulmonary embolism. And then there is subsegmental, but that is too small to be clinical relevant, at least for us. So lobar and saddle pulmonary embolism usually cause a larger degree of embolism, or a patient who has quite a lot of segmental embolism, but the patient is already compromised. So then when you think about pulmonary embolism, there should be a setting. There are patients who have risk factors. So along the next 2-3 slides, I like to enumerate many risk factors. I've taken them through guidelines, through various journals, good review articles. So it can be inherited. So the patients who are having factor 5 laden prothrombin gene mutation, or their prior history of antiphospholipid antibody syndrome. So these are the patients that have inherited syndromes. Then there are acquired. So it is very common in a patient who is having a recent surgery or a trauma. So a patient who is having polytrauma and is immobilized for a long period. Then initiation of hormone replacement therapy or active cancer. So these are very important settings of pulmonary embolism. And there can be non-provoking risk factors like obesity and heavy cigarette smoking. So most important thing when you suspect pulmonary embolism, you should have a setting of pulmonary embolism. Setting means that there should be either inherited risk factors or an acquired risk factor which provokes pulmonary embolism. Then there can be temporary factors and permanent factors. Try to remember the patients, just enumerating them again: patients with malignancy, pregnant patients, patients with OC pills, patients with total joint arthroplasty or replacements, patients with inherited thrombotic disorders, or polytrauma patients or spinal cord injury patients. So these are the very common risk factors that you can encounter in a patients. Then they have divided them into strong risk factors. That means the odds ratio is high. So this is the most common setting of when you have a higher odds ratio. That means the chances of pulmonary embolism in these patients are higher. These are strong risk factors. So try to enumerate or remember them: a trauma patient, spinal cord injury patient, hip or knee replacements, orthopedic patients. Okay. Then patients with MI in previous 3 months, and patients showing heart failure or atrial fibrillation or flutter, or a previous history. So previous history is a very high risk factor. Then there are moderate risk factors. So patients with central line intravenous catheters, chemotherapy, hormone replacement therapies, OC pills, cancer patients, paralytic stroke patients. So these also patients are very common in the ICUs. So they are moderate risk factors. And definitely there are weak risk factors which are present in almost all the patients present in the ICU. Then what is the pathogenesis? Why does this pulmonary embolism or venous thrombosis lead into pulmonary embolism happen? So this is explained by the Virchow triad. Virchow's triad says that there are three things when they are present simultaneously. The chances of venous thromboembolism risk is highest. So first is venous stasis. So the stasis means that the blood flow has stopped in that area. Then there should be hypercoagulability. So as I told, the risk factors that makes either the venous stasis there or a hypercoagulable state or an endothelial injury. So when all three of them, the patients are at highest risk. If two are there, then the high risk is still there. So if you go back and remember the risk factors, you can identify in some patients who are bedridden, there can be venous stasis. In some patients with inherited mutations, will be hypercoagulable states. And others like sepsis, diabetes mellitus, uncontrolled, they have endothelial injury. So risk factors are definitely can be divided into the three virtuous triad also. Now remember what is the pathogenesis. So acute pulmonary embolism, which is a medical emergency by itself, interferes with both circulation and gas exchange. So as an example, the pulmonary artery pressure increased by 30 to 50% of the total cross-sectional area of the pulmonary arterial bed is occluded. So when you have a occluded pulmonary arterial bed, the pulmonary artery pressure rises by a lot of almost 50%. And then pulmonary embolism induced vasoconstriction, that is the markers that are released are thromboxane A2 and serotonin. They lead to increased pulmonary vascular resistance. So there's an anatomical obstruction and there's a hypoxic vasoconstriction that leads to increased pulmonary vascular resistance. So impaired gas exchange from pulmonary embolism is due to the mechanical and functional obstruction of the vascular bed, altering the ventilation to perfusion ratio. And both these mechanisms, mechanical and functional, and the VQ ratio mismatch leads to hypoxemia. Remember this inflammation, this leads to stimulation of respiratory drive. So when you have a patient, he will have hypoxemia. But usually initial stages, they will have respiratory alkalosis and hypocapnia due to increased respiratory rate from stimulation of respiratory drive. Hypercapnia and acidosis are unusual in PA unless shock is present. So when the patient goes to extreme, goes into the shock, you will find the pH dropping to less than 7.4 or less than 7.3, and then gradually when the patient goes down, the PCO2 level rises. Initially, the patient is tachypnic, one of the very common symptoms of pulmonary embolism, and the patient, because of tachypnea, leads to hypocapnia and respiratory alkalosis. Then the cardiovascular effects. So hypotension usually is because of diminished stroke volume and cardiac output. So pulmonary vascular resistance is increased due to physical obstruction and hypoxic vasoconstriction, and the increased PVR leads to impediment of right ventricular outflow and right ventricular dilatation. So all the things, all the findings that you find on the echocardiograph are because of this. There is right ventricular dilatation. Remember that that is present in many cases, but you should have a setting of pulmonary embolism. Then you do a massive pulmonary embolism you suspect, and you do a 2D echocardiography, and you will find many things, and I'll be talking about them. So it causes right ventricular dilatation and flattening or bowing of intraventricular septum. So the septum goes from the right towards the left. So prolongation of RV contraction time into early diastole in the left ventricle leads to leftward bowing of the intraventricular septum. Then there is excessive neurohumeral activation, which leads to both. Can you all mute yourself, please? Excessive neurohumeral activation in PE can be result of the both abnormal RV wall tension and circulatory shock.